difficult for me to understand why they wrote that book itself. Anyway, so this is the first thing you want to remember. All manual therapy comes from traditional medicine. What we mean by traditional medicine is எங்க ஒரு பக்கம் சுளுக்கு எடுக்கிறதுன்னு சொல்லுவாங்க. If you go to US or UK, they will call it as chiropractic or osteopathy because they can name things. நம்ம ஊர்ல ஒழுங்கா பேர் வைக்காம சுளுக்கு எடுக்கிறதுன்னு சொல்லிட்டாங்க. So it's based on that. There is no newer version or anything like that. So you want to remember that. Maitland also read those things and learned those things. From that it was written. So what's the difference between what he wrote and what was traditionally there was there were some extremely violent moments. If you watch YouTube videos, you will see that people going this and that and adding sound effects like the Batman movie, kapang on the face and things like that. Right. So the first difference you will see is there are a lot of gentle passive movements, which is not usually done in the earlier traditional medicine. Even here, they will turn it faster. If you go to a barber shop, everybody knows that they will do that, right? So that is the first thing, and then he made it more systematic within his understanding of what is physiotherapy and things like that. So he made it very systematic and probably scientific within this purview. Am I clear? So this is what is his major contribution, and also I think it's one of the things which has tested, which has stood with time. Right? There are a lot of books you write, it invariably goes. This is of no value to anybody, but some of it is still wonderfully very good. I'll tell you what are the parts. I think it will stand for another 100 years or something like that. Right? It's not going to go away. And then he also had a way of thinking, which is, I think it was one of the cleverest thing anybody could write. He was a certified genius. He was one of the best methods of thinking he could come up with at that particular time, which is fun way of thinking. I still use that, even though some of it is simply wrong, right? So what was the other understanding you need to remember when you are learning things which were written in the 80s or even in the 70s, slightly older, is there is two ways of looking into or thinking. And there is the Aristotelian way of thinking, which is what we all use when we think about ourselves. ஏன் அவன் அப்படி பண்ணா அப்படின்னா அப்படின்னு நம்ம ஒரு காரணம் சொல்லுவோம். ஏன் அவன் அப்படி பண்ணிட்டானா, அவன் ஒய்ஃப் அப்படி சொல்லிருச்சு, அல்லது அவன், we have a logical way of thinking, right? That's what most of medicine was. It is still a logical way of thinking, right? This happened because this happened. A happened because B happened. B happened because of C happened. We have this way of logical thinking. But as we all know that is not how we learn physics, right? We didn't learn physics by logically thinking. If we logically think, most of the physics will not happen. Logically, we may think that how can a tin can fly, but an aeroplane flies, right? We can logically think that we can't have a 500-ton thing floating on water, but we can, because there is a lot of other things to do with that, right? That's what we call as empirical way of looking into evidence. That is, you collect data, you observe data, and you prove the data is true or false, right? So that's an empirical way of thinking. So this was written as a logical book. It was not an empirical book. If Maitland says that if you give grade on manual therapy, he is not talking from, I have done it in 100 patients and 70 patients improved, 30 patients did not improve. He is not talking like that. It is thought from a logical point of view. You have to give one, because the joint is very irritable. I'll tell you what is irritable. So you have to move it less. That kind of logical thinking is what was the book's basic idea. So there are a lot of things which will collapse with time because logical thinking will always collapse, right? Unlike empirical way of looking at it, right? So out of these things, as I told you, the clinical reasoning is one of the fun way to look into what we now call it as I told you, this is the that in one part of the two surfaces, that is, they call as the permeable brick wall. So in one part we have all these things which are basically empirical database things. That is, we now know that there is only one thing called as non-specific back pain, right? So that cannot be changed because that is based on empirical finding. But the other way of, in the other part of it, you move some joint, right? Say for example C4 and C5, you move it and you find there is some issue in that, and then you add these two things, right? So you can go either think with this way or think in that way. You go from here to here. So that is one of the cleverest way of thinking in medicine, because empirical evidence is not fully developed yet. So there is always need for us to have some sort of what we call as intuitive way of thinking. Remember, again, it was written in the 60s, so there was a lot of intuitive way of thinking, right? But one of the problems with this way of thinking is we get stuck with what we call as a biomedical model rather than a biopsychosocial model of thinking. The other thing also is one of the nonsensical things I can ever think of in physiotherapy, what they call as physical diagnosis. This nonsense came from this part of the thinking. That is, low back pain is the medical diagnosis, L4, L5 stiffness or whatever it is the physical diagnosis. This kind of nonsense was from this part of it. Why I still think that it's a good way of thinking, but it is still nonsensical to think that that's a diagnosis. That's not a diagnosis by any stretch of imagination, because that's not the only thing you are treating. That's the first point you want to know. But that's the way it is, right? Right. So if you go to any, I don't know what you learned or who you learned from, nobody will tell you what is the concept of Maitland. It's not very clear what is taught, because some places what I hear from my students, because I have not attended any Maitland course, is that they start with teaching them grade 1, grade 2 or P1, R1. That's the starting point of anything. But as I told you, what is going to still stand after hundreds of years is this, that is, listen to your patient. That is the first principle of Maitland. You have to listen to your patient, right? If you don't listen to your patient, you will not get the diagnosis, because as I told you, because it is in two ways of thinking. One way is you are thinking that it's LBA, but you are trying to find out smaller issues. If you want to find the smaller issues, you will be seeing through your patient's eyes or patient's way of talking, right? So there is a whole chapter on what we mean by listen to a patient. I'm not getting into details of it, but I'll tell you a simple example. நல்லா நடந்து வந்திருப்பான், அவனுக்கு சயாட்டிக்கான்னு சொல்லுவாங்க. I will be very, very confused, right? If he is walking properly, then the chances of having a sciatica is slightly lesser. I'm not saying that he will not have it, or it's slightly lesser. Then if you ask him to, then you ask him questions, what is the pain and things like that. Remember, everybody will say that I have pain here. Any back pain patient will say he has pain here. So that's why you see that every diagnosis I get from, if I get a diagnostic slip or anything like that, it says that most of them seems to have sciatica. Why? Because we don't ask them the next question, right? How is the pain? When is the pain? Is it going away? Is it getting better when you do something? Is it not getting better when you do something? Is it increased when you are doing this and that? All these things are sadly missed out in what we call as consultation. Nowadays there is no consultation itself, right? It's a 5 minutes of வந்துட்டியா ஓகே டயபிட்டிஸா ஏற்கனவே இருக்க மாத்திரையெல்லாம் எழுதிட்டு அதுக்கப்புறம் we see what is the sugar levels, which again is a biomedical model. It is not a BPS model, right? So this is still happening in every field. That's why I'm saying that this part of listen to your patient is going to give you lots of information, especially which joint is affected in his whole way of understanding. Which joint is more painful, doing when is it is more painful, when it is less painful, right? These kind of things are still vital part of any consult, right? So that is the first thing in your assessment, right? Or that is the first part of your Maitland's concept. The second thing and third thing and fourth thing is fairly simple. You plan a physical examination. Remember, you plan a physical examination. That means your plan is based on what your patient told you, right? Yesterday we had a sort of an online teaching with in a Bangalore where they did a case presentation, right? Neurology assessment நம்ம எழுதுவோம் இல்லையா ஸ்கூலில் காலேஜ்லலாம் ரிஃப்ளெக்ஸஸை செக் பண்ண இன்க்ரீஸ் ஆகிருக்கு டிக்ரீஸ் ஆகிருக்கு range of we write the whole bunch of things. I did 2-point discrimination, 3-point discrimination, all sorts of things we keep on writing. Why? We don't know. We write it because we were told to do that, not because my patient came and told me my reflexes are more or reflexes are less. What is it telling me? அதை குறைக்க போகிறோமா கூட்ட போகிறோமா அல்லது அதிலிருந்து are we planning and treatment? Nothing, right? So that's what I mean by listening to your patient is going to be going to stand the test of time. So accordingly you plan your examination and then you do your examination and then you do your manual therapy. The manual therapy is sort of straightforward, but probably will take you anywhere from 6 to 1 year to do it properly, right? It might take you more time also. It took me 1 year, so I'm assuming it may take less time for some people, but it took me a lot of time, so I'm thinking like that. So what is examination, right? As I told you, this is a biomedical model. It is not, we are not trying to find out what is the psychological state of the patient and things like that. You can, but that doesn't come here. But you have to remember that, right? But in this, this is fairly slightly, as I told you, within the purview of biomedical model. That is, what is the biological issues with your patient, right? So they have, they observe, so if you are like this, they observe the whole idea of sciatic scoliosis, all these things come from the observation part of it. Remember, again, it's in the purview of biomedical model, nothing to do with anything else. And then they do active movement, passive movement, palpation, special tests, all sorts of things you do, right? But what is slightly special, or what was Maitland telling us to look into for is, as I told you, is it an issue in the hip or is it an issue in the ankle? Basically, what is the biological tissue which is underlyingly a problem? Now, in case of, as I told you earlier, it's based on passive movements. You move your joint and find out whether the joint or any structures around the joint is having an issue, right? So you do 3 types of movements. One is he called the physiological movement, that is flexion, extension, rotation. So if you're having any pain or stiffness in these movements, you look for. And then the accessory movements. The accessory movements are, I'm assuming if you have gone to post-graduation, they will tell you anterior, posterior. So you do all sorts of accessory movements. And the last is you combine accessory with physiology, or you even have combination of physiological movements. I still do these things, not for finding out what is the source or anything like that, but it gives you a clear idea of what is what and things like that, right? But as I told you, the simple idea is, can you come and sit here so that we can, so if, what I mean by that is, if you're testing this, this is your physiological movement, and if you are trying to press on, say for example C5, and see if there is any muscle stiffness, or it's not muscle stiffness, any stiffness you are feeling, or if you are feeling any pain, if the patient is telling you it is paining, that you look into. Or you can add this kind of movement where there is flexion and then rotation, this kind of things. That's what they mean by combined. Right? So these are the basic nuts of. So the next question is, okay, what is it you're checking for, right? Okay, you're moving like this, moving like this. What are you looking for? If you ask any person who has gone to Maitland, even if they don't understand, they will tell you this, SIN. SIN is a good acronym they have for in physiotherapy for Maitland's approach, especially if you have gone to college like I and Hari in the 90s. SIN was a great thing they will ask you in exam. Even though examiner didn't understand, we also didn't understand, but we told something. Anyway, so the first thing he was talking about was, remember, it's a biomedical model. What it means is nociception is equal to pain. Right? So if you move a joint and if it is very painful, right, or it is very much evoking the symptoms, that's what they mean by irritability. The joint is very irritable. If you just give a small movement like this, right? If you give a small movement like this, it's the patient is wincing with pain. Rather than doing this, if you do this, right? I am just moving the carpal bones like this, metacarpal bones like this. If it is painful, that means that it's very severe, right? Remember, these are all logical ideas, right? So if the irritability, it's irritability. If there is more irritable, then the assumption in Maitland is it is more severe. The nature of it is sort of very, very severely affected joint. The common example I can tell you is, if you have acutely strained your ankle, acutely strained your back, if you touch it, it will be very, very painful, right? So that's what he meant by irritability, and the joint is very irritable when you are having a lot of things, right? Remember, this is not for a condition, this is for anything. So even if you have nerve pain, and if you are moving it, and if it is very irritable, then they will call it as a highly irritable joint, or a highly irritable symptom, if you, right? So in that, within this idea of irritability, some joints are less irritable, right? So for example, the easiest way to understand this is periarthritis shoulder, or adhesive capsulitis. In the acute stage, if you move the joint slightly, the pain is very, very high. The joint is very, very irritable. As time goes by, when they come after 1 month or something like that, you can see that they will start to have pain. That means the joint is less irritable. So at that time, what are they trying to find out is two things. One is R1 and P1. It can be here or here, that doesn't matter. P1 is where your pain starts. If I am moving this joint and he is saying that here I am having starting of the pain, right? That's called as a P1. And if I go here, then he says not more than that I am unable to. That is your P2, right? So you'll have a starting of pain and then kind of. So they will go for P1 and P2. Remember, as the joint is moved more, the irritability is also going to be more. Am I clear? If you are moving the joint more, it's naturally the joint is going to be more and more irritable. The symptoms are going to be more and more. You can also have R1 and R2, right? What it means is where the resistance sets in, or the patient is resisting you, and after a particular range he is saying that no more, I can't move that beyond that, right? So for example, I can't move this joint beyond this. That will be my, in a normal range, this will be my R2, right? Beyond this I can't move it, so that's your R2. These are not very complicated, but first time you hear it sounds slightly complicated. So what they are trying to find out is, when is your pain starting? When is your pain at the highest level? When is your resistance starting? And when is your resistance at the highest level? இப்போ நீங்கள் பிஹெச் ஷோல்டரில் பார்த்தீங்கன்னா இதுக்கு மேலே தூக்கவே முடியலங்க அப்படின்வாங்க. பட் கொஞ்சம் என்கரேஜ் பண்ணிட்டீங்கனாலே லாட் ஆஃப் பீப்புள் வில் கம் ஹியர், ஈவன் ஆக்டிவ்லி, right? So passively you will get that starting and ending. That is your R1 and R2, right? So you go back to this, and now you see you can find out R1 and P1 and P2 and R2 in any of these movements. That is, you move the joint like this and see, okay, this is P1, and you can go this as P2, right? Or you can, as I told you, you can press the, give an anterior posterior pressure and see where the P1 starts and P2 starts. Or if you are done this and you are thinking, your patient is also telling, இல்லைங்க என்னால் அண்ணாந்து பார்க்குறது தான் ரொம்ப கஷ்டமாக இருக்குது, திரும்பவும் முடியல, அண்ணாந்து பார்க்க முடியல அப்படின்னாங்கன்னா, then you do this also, right? And then you want to also know whether it is combination of anandu pakamla, also can't do a rotation. Then you add these two movements and see where you are getting your P1 and where you are getting your P2, right? Is the joint more irritable, less irritable? Where is your pain starting? Where is your end starting? So the whole idea of what a manual therapy should be is based on these kind of things. So they, again, one of the classical genius of Maitland was, he never told that this is this condition. That is, he didn't use what they call as now as physical diagnosis, right? He was very clever in that, because he knew that these are not solid things. It's not going to be there in all our patients. So he used a broad idea where he said that there is a group of patients who have pain is the predominant factor. Pain is the biggest thing, right? As I told you, any acute injury, probably this. Any sin, in the sin part of it, when irritability is higher, probably this group, probably. Then there is a group which is more stiffness is the biggest thing, right? Like in post-traumatic stiffness, that kind of thing. Again, he didn't use the word post-traumatic stiffness or anything like that. He just said that some people have a lot of stiffness, right? It can be also third stage of your PA shoulder also, where the stiffness is the biggest problem. And then you have a group of people who have stiffness and pain. Probably that's what we all get in our day-to-day practice. Most of them come with pain and stiffness, probably any LBA patient, any neck pain patient, right? And then the subgroups, they will tell you that did the P1 start before R1, or the R1 start before the P1? That is, if the resistance starts if the pain starts before the resistance and the stiffness starts before the pain. This is where I think this is utter nonsense. Nobody can find out. It took me 5 years to understand that I am fooling myself, right? But that is the basic idea. But you can practice Maitland with these 3 groups. இதெல்லாம் கண்டுபிடிச்சு ஒரு மாடை மேய்க்க தேவையில்லை. Right? So you just have to know that, okay, am I treating pain? Am I treating stiffness? Am I treating pain and stiffness? Right? Why? Because if this is the biggest problem, the sin part of it, the severity and the irritability will be more. The irritability will be less. So the basic idea here is, if it is more irritable, then move less. The movement should be lesser. The movement should not go into the pain. Am I clear? If there is a lot of pain, the movement should be lesser. The movement should not get into the pain part of it. This is where I told you it is different from the earlier versions of violent movements and doing it, whatever happens, you just move it like that. And here, the movements will be more harsher, if you will. They will move into the joints. The oscillations will be slightly lesser. You move more and more and more. And again, in this group, in the Maitland book itself, it will tell you that you have to use more physiological movements, not accessory movements. Right? So in PA shoulder, third phase, they have more stiffness. It doesn't matter whether you do anterior posterior mobilization or telescopic movement, whatever movement. It doesn't matter. That's what he seemed to suggest, which seems to be a logical thing to do also. And if you have this, depending on when the P1 starts and what is the differentiating between P1 and R1, they will make some kind of decision making, right? There are lots of books based on this decision making. Especially there was this guy called as Mark Jones, who wrote extensively on these things. If you go and read it now, it will look like somebody scribbled on a paper. It doesn't make any sense at all. It's just rubbish, right? But as I told you, because they were over-interpreting a lot of things, right? So what will they do? I think everybody knows that there is 4 grade of manual therapy. The grade 1 is very, very small. Professor Dandamani used to tell that grade 1 should be like on a spring, fly sits on the spring, that much force should be there. And I was fascinated by the idea. And again, it took me 5 years to know that that is nonsense. There is no grade 1, or it is not there, or you don't need that at all. So what the idea is, if it is very, very severe pain, you move it like this. இவ்வளோதான் movement. If he walks and comes, right, that is happening inside, right? If you are acutely injured, ankle injury, na இப்படி குதிச்சு வந்தான்னு வச்சுக்கோங்க, you are having grade probably 3 or 2. அவனுக்கு வந்து நான் லேசா மூவ் பண்ணி, it doesn't make sense. But that's that, right? But as I told you, logically it makes sound because it's very severe. Move less, right? But anyway, we will not worry about one. So this is the, as I told you, this grade makes sense when you have found out R1 and R2 or P1 and P2. Otherwise it doesn't make sense, right? So if you are grade 2, right, we will consider this as a P1 rather than R1. If you are not going into the moment, and இங்க இந்த இடத்துல வரும்போது எனக்கு வலி வருதுன்னு வச்சுக்கோங்க, 90 degreesல எனக்கு வலி வருதுன்னா, if I am moving this, then I have to do a sort of a law. The oscillation should be larger, right? The passive movement should be larger, and I have to do it sort of rhythmically. Pain குள்ள வராம பண்ணிட்டே இருந்தோம்னு வச்சுக்கோங்க, That's what he said as 2. Again, this is for when the irritability is higher, right? So this is what I mean by the difference. இப்போ இங்கே வந்தோடனே எனக்கு வலி வருது அப்படின்னா பொதுவாக மேனுவல் தெரப்பியில் என்ன பண்ணுவாங்கன்னா அப்படி ஒரு சொடக்குன்னு போடுறது தான் வந்து that was the idea. Here what he said, no, don't go there, move this itself, right? He is very sad. Right? So rather than, sorry? So he said rather than getting into the pain, go away from the pain. This is a good idea if you are starting with manual therapy. If you are not, don't worry when to use 2, when to use 3, when to use 4. Nobody knows. It's all, they will call it as, that's where the art comes. What it means is we don't have the slightest clue, right? So that's the right answer. So you can try this with, as I told you, with a single joint and then a combination of joint movement. And he is so happy today, right? So you can try. 2 is when your pain is higher, if you will, and 3 is you go from again from up. Pain ஆரம்பிக்கிறதுக்கு முன்னாடி you have to start and then get into the pain. You're going slowly into the pain. So if you're having pain like this, you can keep on do this, right? And probably is okay. So that is your 4 or 5, right? If you do a sort of a movement inside the joint and it goes into your nearly to your anatomical limit, they will call it as 4 or 5. Again, I would advise anybody not to do that because there's a very, very, very small chance of injuring your patient, especially if you are an older patient. Again, you will see that all the videos they put on chiropractors, they will be all young people. Older people are putting, sometimes you will be like, oh my God, this should be attached to this. So, I get that, but no, they have pain. The only thing you will see in all the videos, they will check by themselves whether the patient has got better, right? They will tell you, see the range is better, see the leg length has got better. No, ask that person lying there. That's what I told you is the first rule of Maitland. Listen to your patient. Don't tell yourself you are going. That is not for you to say, right? That's why I told you that the genius idea is you have to listen to your patient saying whether he's got better or not, right? So you can't tell by saying that, see, I have improved P1, R2, or this and that, right? So that you want to remember. So when to use it or not, as I told you, the basic idea is this: if the irritability is more, don't get into the pain range. Move the joints gently. If it is less irritable, end range, some people may say that only at the end I have pain. Then probably you can do a grade 4 or something like that. When to do grade 1, as I told you, never. It's not. It is of no value at all to anybody, right? So that is the basic idea of what is Maitland. So there are few questions which, as I told you, Saran used to tell me that it took him probably 1 month to know that whatever he learned in manual therapy is not going to work in his patients. Sadly, it took me probably 5 years or something like that to understand that this is not working. One of the reasons for that is, as I told you, most of the manual therapy, when you are learning enthusiastically, you are not listening to your patient. You are just thinking, "Paathiya, kalathu enga kondu vandendradha vandu." That's what happened to you, right? It happens to everybody because you have not moved the joint in that direction ever on another human being, right? So it's fascinating to do that, and you don't listen to your patient too. And also the next thing it struck me is that this struck me slightly earlier. You can't do that on older people, right? And sadly, most of my patients are older people, younger people. So, and also if you do it on some people, they will be like, "Why did you do that? Don't do it on me," right? So again, that comes from the problem of listening to your patient, right? You have to tell them that you are going to do that, but in all your enthusiasm of learning these things, we tend to forget that. Correct, right? And the next thing you want to remember is the cracking sound, what you heard. It is nothing. It's just a sound, right? But as in a movie, if you have a gun sound, if you have that sound, then only you feel like, "Oh my God, this is violence," right? This is something is happening into me. It is pleasuring me, right? Likewise, it's a pleasure sensing for your patient as well as yourself. That's the point of the sound. Nothing to do with I have opened the joint, okay, realigned the joint. The realignment is just a nonsensical word. Again, this is the genius of Maitland. He never used any of these things. But subsequent people who teach these nonsense, they just don't read anything. They just keep on adding from here and there, right? The other model, which I'm telling you some of the things which are not working also. If you learn Maitland, the difficult things will be differentiating between ankle joint and talocrural joint, or between ulnar radius and between your carpal and the ulna, or carpal and the radius. These kind of things are complicated maneuvers are there. Whether to differentiate between, how to differentiate between the hip and the knee joint. Now we all know that that is not happening at all. We can't differentiate, or it doesn't matter at all. Of course, we need to know whether it's a hip joint pain or a knee joint pain. That's not what I'm asking. A lot of people tend to think that hip joint pain will show as though it's a knee joint pain, so I have to treat the knee joint pain, treat the hip joint pain, that kind of thing. This was overemphasized by another woman called as Sherman. If you have ever read a book on Sherman, you are just an unlucky person. She is just utter rubbish, right? So that kind of thinking is also sort of whether it is talocrural or ankle joint, I will move the talus and then I will see whether I can know. It's not happening. Why? Even if you are thinking that I am doing a anterior-posterior pressure on C4, C5, right? If you press on C5, right, the pressure is going to go up to here. It's not going to go only on C4, C5. Why? Because all the vertebrae are connected by lots and lots of ligament, right? Lots and lots of muscle. So we know that the pressure distributes like that. It doesn't go straight away into that. So these are some difficult things, right? If you want to understand like this, you want to read a book called as Modern Manual Therapy by Greaves, which is a far more complicated book, a far more better read than any Maitland book. any manual therapy book you can ever read. Again, it is also it also has its own problem of being a biomedical model, not a biopsychosocial model, right? And again, if you want to know why manual therapy, a lot of problems in the manual therapy, again you want to read Clifford. He was the first to say that, really, if you are doing this, you are moving the nerve. Are you sure you are not moving the muscle? Are you sure you are not moving the tendon? Right? So a lot of people tend to think that இப்படி பண்ணா now அந்த slide பண்றோம். You may be doing a lot of things, not just nerve alone, right? So these kind of questions are still there. And the last thing is, as I told you, we are not very sure still now whether we now know very well that irritability does not mean more severe, right? We know that nociception is not equal to severity or anything like that, right? Even people who have had pain for years together are having a lot of, if they are very afraid to turn. So that is another problem. Because that is a problem, which grade to give is not very clear. But as I told you, still what is good about this thing is, as I told you, it still allows you to think like in compartments between the logical thinking and empirical thinking. And also it still gives you a sort of lot of leeway on saying that I'm moving this joint or moving that joint, or I'm tendon on the sari pandren, or I'm moving the nerve. These kind of utter rubbish. It's always better to think like Maitland said. You're moving in a particular manner using combined movements. This is basically a combined movement. He is not telling you you are moving the nerve or anything like that. But he might think like that also, because he was one of the proponents of slump test and things like that. But you can have a modification of that. The last thing I'm still, as I told you, it's better to have non-violent movements, if you will, rather than having violent movements in terms of manual therapy. But out of all these things, what is still the best thing about Maitland is it tells to listen to your patient, not to think of yourself as the end range feel or 10 நாள் எடுப்பாங்க. Nobody understands what it feels. அப்படியே அப்படிங்கடனே எல்லாரும் மண்டையாட்டிடணும், கோர்ஸ் முடிஞ்சு போச்சு. So these things are not very well defined, or it's not possible to do all those things. Right? So if at all you are starting with any manual therapy, start with the Maitland and end with Maitland. You don't have to go anywhere. If you want to understand it more clearly, probably Greaves manual therapy, or start with Clifford. Right? So that's it about Maitland, or what I think is Maitland, because as I told you, I have not learned from Maitland himself, so I don't have a clue. But the book is written in English, so anybody can read and understand. So if you have any questions before we leave for